Good afternoon. Welcome, everyone. Thanks for joining us today. My name is Deborah Holloway. I'm the Education and Resource Coordinator at the Brain Injury Association of Virginia. I just wanted to let everyone know that this project is supported in part through state general funds from the Virginia Department for Aging and Rehab Services. I also wanted to let everyone know that we are going to be recording this presentation for future viewing. Real quick, I wanted to just share a little information about the Brain Injury Association of Virginia. As you will see, there's our mission and also our website if you need more information. And I also wanted to share some of the activities we have coming up. We do annual conferences. We have one coming up in March and another one in May. Webinars such as these that target educational opportunities for all kinds of families, individuals with brain injury, and professionals. We do statewide advocacy. We're hosting a caregiver forum this fall, which is coming up in November, so you can visit our website or email me if you have questions about that. That's a day-long small group that gets together to help support those caring for individuals with brain injury. We have a robust website with lots of resources. We have a chat feature that's available during the day. We also host a 2-week camp in the spring for adults with brain injury. And we have an annual golf charity. There's my contact information. Along with being recorded, I also wanted to let everyone know that there are 2 handouts available. They are to the right of your screen. There is the Center for Neurologic Study Lability Scale, and that's a short self-administered questionnaire that's available for someone to download and review, and something you can do on your own. CEUs are not being offered for this webinar, but we do offer a certificate of attendance, and you can also download a copy of that certificate as a handout to the right of your screen. I'm going to go ahead and introduce our presenter today. Okay, and turn things over to Kevin. Our presenter for today's presentation, What is PseudoBulbar Effect, is Dr. Kevin Winterling. Dr. Winterling earned his PhD in molecular genetics at the University of Maryland, Baltimore County. Then he's worked as a research fellow at NIH before becoming a biology professor at a small liberal arts college in Virginia. He's worked in a variety of clinical and medical roles in the pharmaceutical industry over the past 14 years. He's currently a scientist in medical affairs at Avanir Pharmaceuticals, and his focus is neurobehavioral disorders that are associated with brain injury and neurodegeneration. And he is currently living in Richmond, Virginia. And I'm going to turn things over to Kevin.
Okay, thank you, Deborah. You hear me okay?
I can hear you okay, and if you can just, okay, making sure that everybody can see your screen, great.
Okay. All right, well, thank you very much for the opportunity. Good afternoon, everyone. So today I'm going to be talking about PseudoBulbar affect and what it is, and from this point on, I'll mostly refer to it as PBA, which is understandable. PBA is a lot less of a mouthful to say. So I will, throughout the presentation, give a little bit of background regarding communication disorders of emotions. Then I will talk about what PBA actually is, and then we'll discuss the impact or burden that PBA can have on, mostly on patients, but also the impact that there is on caregivers as well. And then feel free to submit questions throughout the talk, and then at the end, we'll answer those questions as best as we can. So, brain injury and stroke, PBA is found in a number of neurological conditions that involve lesions to the brain, injury to the brain, or degeneration that occurs in the brain. And there are a lot of statistics out there. As far as traumatic brain injury goes, in 2013, was reported to be almost 3 million incidents in which patients went to the emergency room or were admitted to the hospital or even died. And so those are just the people that were recorded. So this is a relatively conservative estimate, and it's 5 years ago. So that number is probably significantly higher than that at this point. One of the points I want to make, however, is that the signs and symptoms that an individual does experience as a result of a brain injury is very much linked to where the location, the anatomical location of where the injury actually occurs. So depending on where it occurred, it may have a significant impact on speech, it may have impact on communication, motor skills, and so on. So that's going to be a theme that I'm going to continually circle back to, is that depends on the location of the injury or the degeneration as to what the symptoms actually look like. So numerous patients on the webinar and your caregivers, so you know what it's like living with brain injury. The majority of patients who've had a brain injury, survivors of brain injury, require some form of rehab. There's the acute phase, and that goes on to a chronic phase that may involve a lengthy stay in a rehab facility, and then for some people, years and years of continuous outpatient therapy, in which the goals are to either help survivors regain skills that they may have lost as a result of the brain injury, or accommodate those skills that have been lost. And there are a number of buckets in which we can categorize the types of disorders or types of disabilities that occur, and they can be motor, they can be sensory, they can have to do with cognition and ability to remember things, even behavioral, emotional types of things. But another one of those buckets on which I'm going to focus is communication. So how do we communicate? So I'm sure a number of you have had therapy, or your loved one or person you know that's had a brain injury has had therapy with a speech pathologist who worked on different forms of communication, whether it was the ability to find words or articulate words. That is one form of communication that is verbal. So verbal communication are the words that we use, how we link those words together, the phrases or the sentences that we use, and really we can think of the use of words as a way of communicating what we are actually thinking. But there are even some subtleties involved there depending on your background and your culture. So for example, I can say that last week it was raining cats and dogs. And most of us, I assume, on the webinar know what that means. It means it was raining very heavily as a result of the hurricane. But someone from a different culture or a different country may not know what that means, even though those words are there. They may actually visualize that animals are falling from the sky. Another part of our communication is nonverbal. And actually, that's the majority of our communication, especially interpersonal communications, when we're interacting with a few people or one person. As much as 80 to 90% of our communication can be nonverbal. And that involves the expressions in our face, our body language, and emotional expressions such as laughing and crying. And really, our nonverbal communication skills are designed to let people know how we feel. So the words we use are letting people know what we're thinking. The nonverbal things that we do let people know how we feel. So it's a little bit of a struggle for me today, not being with all of you in person, because you cannot see my face. You can't see my expressions. You can't see me waving my hands around and pointing to different things. So it takes away a little bit of my ability to communicate because you can't see that. But what you can do is hear in fluctuations in my voice. So for example, it's not just what we say or the words we say and how we link them together, but the tone that we have. So I may ask someone while I'm sitting at the dinner table, would you please pass the salt? And I'm bringing across a very pleasant, congenial type of communication. But if I say the same words with a different tone, in essence, would you please pass the salt? I'm coming off as being angry or irritated. So just driving home that there are different ways of communicating, and our nonverbal parts of communicating are extremely important. So in continuing with that nonverbal communication, I said that our nonverbal skills are used to communicate how we feel. A couple emotions, a couple of definitions based on what we mean by feelings. So very often feelings involve emotion, and that's really what are we projecting, how do we feel about people or a situation that is occurring. And we branch that off into two things, and one of those is mood. And mood is sort of how are you feeling overall? Are you happy? Are you sad? Are you energetic? And affect is another term that we use. That's how we're feeling at this given moment and how we're coming across. Again, it has a lot to do with the tone of how one communicates. I can become very robotic in the way that I say my words, and I have a flat affect. And that's not very good, right? I'd put you all asleep in a few minutes if I haven't done that already. I can have an energetic affect. I can be high on energy and talking quickly. I can be happy. I can be sad. So that's sort of what we mean by affect. Whereas mood is your overlying state, affect is what you're communicating right now with your mood. When in discussing PBA, I want to be clear that there are a lot of different emotions and there are a lot of different feelings. And with neurological disorders, such as brain injury, a survivor can experience a lot of different unique things with emotional expression. And one might experience agitation or anger or disinhibition, irritability. All those things are very important. But when one talks about PBA, PBA becomes very narrowly focused in the definition of the disorder. PBA deals with only the emotional expression of laughing and crying. So I'm going to focus on those two components of emotional expression, even though I know a lot of survivors of brain injury have a lot of other emotions that with which they're dealing. So why do we laugh and cry? And there are a lot of crazy explanations out there. People have been trying to come up with explanations really for thousands of years. And even from a scientific perspective, people have been trying to come up with explanations as to why we laugh and cry for a few hundred years. And the interesting thing is that humans are the only animals that laugh and cry. So cry tears and laugh. So it's something that is unique to humans. So going back, some people thought that there are crazy ideas like the reason we cried was because we had evolved from some sort of aquatic or sea living primates, and tears were a way that we kept our eyes clear. Or that when we get really stressed, we have toxins that build up in our bodies. The only way to get rid of those toxins is to cry. I don't think that those hold a lot of weight. And really what I think is that they are forms of communication. And I think they're forms of communication that developed or occurred thousands and thousands of years ago before humans had very complicated, well-developed language. And that was how individuals let people know how they were feeling. And think about it, it also elicits very strong responses from other people when we laugh and when we cry. When we cry, it tends to generate sympathy from others or feelings of they want to help. Sometimes it can make people want to distance themselves because they don't understand the crying. When we laugh, individuals around us may feel a sense of joy depending how we're laughing. People, if you have a maniacal laugh like an evil villain, may feel a sense of fear. People may feel, if you're laughing at them, they may really feel a sense of anger and frustration towards you. So the emotions of laughing and crying are very powerful forms of communicating with the others around us. The important part that I want you to take home and take to the next step, though, is that emotions are initiated or originate within our brain. And it hasn't been completely 100% understood by researchers and neurologists, but it's believed that the process goes something like this. So we have this sort of green section of the brain that is responsible for, in our cortex, that is responsible for regulating how we express our emotions. But we have this other part of the brain down here called the brainstem and the cerebellum that are responsible for actually causing our emotional responses of things like laughing and crying. And there's this network of communications between these different parts in the brain that allow for the appropriate emotional expression. And it's almost like this green area either turns on or turns off a spigot, if you will, or a faucet that allows emotions to be expressed, or when it's appropriate, keeps those emotions sort of tamped down so that they are inhibited a bit. Now, when a brain injury occurs, it can have an impact on those pathways that communicate from these different areas of the brain. So if this area up here that I mentioned before was green or in the cortex is injured, or any pathways between it and this part of the brain in the middle, the brainstem or the cerebellum, are disrupted by an injury, physical injury or stroke, or other neurodegenerative diseases, it can have an impact on the way the different parts of the brain talk to each other, and therefore it can have an impact on the way emotions are expressed. And again, it depends exactly where the damage is or where these lesions is as to exactly what that might look like. So finally, that's a fair amount of background on how important it is for us to be able to have emotional communication, how it enhances our ability to verbally communicate, how our emotional expressions can really elicit strong responses from others around us, and how that's linked to very specific areas of the brain and that injuries can impact that. Moving on now to the specifics of PBA or pseudobulbar affect. And again, remember, pseudobulbar affect deals only with laughing and crying, the expression of laughing and crying. So very simple definition is that PBA is marked by episodes of laughing and or crying that are sudden, frequent, and uncontrollable, and essentially out of the norm. Laughing and crying did not happen this way in the brain injury survivor before the brain injury. And we can't account it to some other type of disorder. It's not due to medication or using illicit drugs or alcohol. It has to do, it is secondary to a neurological condition. And in this case, you're most interested in how it's secondary to brain injury. But the interesting thing about PBA is it looks the same regardless of what the neurological condition is. So PBA is examined extensively, not just in brain injury, but it's also examined in stroke patients, dementia patients, and Alzheimer's, individuals with movement disorders such as Parkinson's disease. It is seen in ALS, and it's also seen in MS, multiple sclerosis, and it looks the same. And what all those diseases have in common is that there are injuries or disruptions in the pathway of the brain that regulate the ability to emotionally communicate. Now to go into the symptoms of PBA in a little more detail. As I mentioned, they are sudden. They can come on without warning. Some patients, after years of struggling with PBA, may be able to predict situations and what it's going to happen, or there may be triggers. They hear a certain type of song, or they're in a certain situation. They know that they're at greater risk for having, but for the most part, they come on very suddenly. An individual with PBA may be fine 1 minute, and 20 seconds later, they're crying uncontrollably. These episodes are also frequent, and so I want to go through a little bit of data or numbers to communicate how frequent episodes of PBA can be. So let's go back to crying, and I mentioned that crying is an effective form of communication. So newborn babies cry a lot, and some studies have shown that newborn babies cry as many as 30 to 35 times per day. And that makes sense, correct? Because a newborn hasn't developed language skills, hasn't developed verbal communication. And really the only way that that newborn, or the most effective way that that baby can communicate, is by crying. They cry if their diaper's wet, they cry if they're hungry, they cry if they're cold, they cry if they're tired. And so 25 to 30 times a day, it's a lot. May even seem like more than that at times. So as a baby's language skills develop and they grow up and they get older, individuals cry a lot less as they become adults. But we still cry on occasion. And on average, an adult female cries about 4 to 5 times per month. So that's still about 36 times per year, but obviously a lot less than a baby cries. And then adult males cry even a little bit less. Studies have shown that an adult male may cry about 5 times per year. Unless you're like me, I have 3 teenage children, I probably cry a little bit more than 5 times per year. But that's a different story. Now, individuals with PBA, there are numerous studies have been done that look at treatment options of PBA, and individuals are screened, and the researchers believe that individuals coming into the trial, there's a very good chance that they do have PBA, they're diagnosed with PBA. On average, those patients entering trials for treatment of PBA have 5 to 7 episodes per day. And it's not always crying, it can be laughing also, or it can be a combination of laughing and crying, of 5 to 7 times a day. So if we do the math and take that out, that is almost 2,000 times per year that an individual has an uncontrolled episode of crying and or laughing. So it's not quite on the magnitude of a baby or a newborn, but not even close, significantly way more than what a typical adult male or female would experience. So a lot of frequency. And finally, they're uncontrollable. So once an episode starts, nothing can be done to stop it until it rides itself out, and nothing can be done to prevent this episode of crying or laughing. And it seems that there are two ways that it can happen. And the first one, which is first bullet point here, we call these incongruent episodes, which just means it's not in line with what the situation has. So a lot of times it can be opposite to the situation, where an individual may be in an environment that's happy. You may be at a birthday party, or you may be bowling or at an athletic event, and everyone's having a good time, and then all of a sudden someone begins to cry uncontrollably. Or we can have the other situation where one may be at a funeral, or one might be at a church service, and they begin to laugh uncontrollably. So those are the episodes of PBA that are easier to recognize and pick out. And unfortunately, from a diagnostic perspective, these are not the majority of PBA episodes. They probably account for about 30% of the episodes of PBA. What accounts for the majority of those is the second bullet point, which we call exaggerated episodes. So there may be a mildly sad situation, but the patient with PBA then has a 2 or 3 minute fit of uncontrollably sobbing. There may be a situation where there's a commercial on TV, or it may be a situation where one goes to a funeral for an acquaintance, and it is a sad occasion, but this person seems to be, with PBA, is crying uncontrollably throughout. The opposite can happen as well. It may be a situation where professional setting or a somber setting, someone tells a little story that's humorous or tells a joke that may get a smile or chuckle, and for a patient with PBA, they bust out laughing hilariously, can't stop laughing for 30 seconds, 45 seconds. So that is the majority of types of things we see in PBA. One patient that I had the opportunity to interact with, who had a number of concussions from bicycling accidents, went to church service daily to help her deal with emotionally the disability. And at church service before her injury, she would feel a little bit emotional or emotionally moved. But since her injury, she cries throughout the entire church service and goes through a box of tissues while she's there. That's another good example of an exaggerated episode. Okay, so I'm wondering how many of you had heard of PBA before, or know of someone who's had episodes of PBA, or if you yourself have had episodes of PBA. Well, how common is PBA? So a survey type of study was done to examine the prevalence of PBA in individuals that have different types of neurological disorders, such as brain injury, stroke, ALS, MS, and the other things that I mentioned before. So there are 6 common underlying neurological diseases. So these were patients that were already being seen by a physician for their neurological disease, and about 5,300 of them were recruited and questioned about symptoms relating to PBA. And Deborah was kind enough to share in an attachment a document that is the CNS-LS. And again, that stands for the Center of Neurologic Study Lability Scale. And it is a self-administered, so patient-administered or caregiver-administered screening tool to see if there might be something going on with PBA in that individual. And it's 7 questions, and 4 of the questions deal with crying, and 3 of the questions deal with laughing. But studies have shown that if an individual gets a score of 13 or higher when taking that, there's a pretty good chance that they may have PBA. And it's about 83 to 85% accurate in predicting a diagnosis of PBA. So these 5,000 plus patients who are already seeing a physician or a neurologist for their neurological condition are given this screening tool, the CNS-LS. And the data comes back that shows that overall, out of all 5,300 patients that were asked, about 37% of them get a score of 13 or higher, and suggestive that they may have PBA. And in your specific population of traumatic brain injury, 52% of the patients had a score of 13 points or higher, again, suggestive that this is something that may want to be looked at further in there. Now, again, I want to stress that getting a score of 13 or higher does not mean that an individual does have PBA. It is not a diagnostic tool, but it is a good way of determining whether or not this should be explored further with a healthcare provider. So overall, about 37% of patients have signs and symptoms suggestive of PBA, and in traumatic brain injury, over half of the patients get a score that is suggestive that they may have PBA. Well, so that's a lot. And when I go out and I talk to physicians that work with these neurological disorders, rarely do they have that many patients that they've diagnosed with PBA. And I'm sure that the audience to which I'm speaking probably doesn't match that as well. So if there are these studies that have been done that show PBA is relatively common, 37% of patients with certain neurological disorders, why don't we see that many people actually diagnosed with PBA? So in another type of survey that was done, in which almost 1,000 people, 937 individuals, were given came back with a score of 13 or higher when given the CNS-LS. The majority of those patients did not even speak to their healthcare provider or anyone else about the symptoms they were having of uncontrolled laughing and crying, sudden uncontrolled laughing and crying. So only 33% of them actually told anybody about it. So that's the first step, is that patients and caregivers may actually see the signs and symptoms, but they don't feel comfortable speaking to anyone else or a healthcare provider or their doctor about it, because they think, oh, this is just part of the process. There's nothing I can do about it, or people will think I'm crazy or I'm embarrassed by it. So the majority of people don't even mention it. And of those people who actually do mention it, about a third of them, they get diagnosed most often with depression. And again, I understand that makes sense, especially if it's related to crying. If someone has uncontrolled episodes of crying and you've experienced a brain injury and that's had a negative impact on your life, and we automatically associate crying with being sad, that makes sense. If you're crying a lot, then you must be really sad, and it makes sense because you have a brain injury and therefore you are depressed. And sometimes that is the case, but it's not always the case. And as a matter of fact, if you look at the psychiatric or psychological criteria for diagnosing depression, crying is actually not one of the symptoms of depression. So people who are depressed don't always cry. So this uncontrolled crying sometimes is a sign of depression, but oftentimes is not. Other patients are often told that these emotional outbursts of laughing or crying are just part of the disease state, and there's nothing that you can do about it. And they're given a variety of other diagnoses. One significant thing here is that of the 227 patients who spoke to their healthcare provider about these signs and symptoms and had a score on their CNS-LS of 13 points or higher, not a single one received a diagnosis of PBA. And so that's a lot of what my employer and I need to do a better job of, and it's why I'm doing this webinar, is to increase the awareness of PBA so that when people have it, they do get the proper diagnosis. A little bit more on the association of crying and depression, since this seems to be the main diagnosis that patients who potentially have PBA and have a score of 13 or higher on their CNS-LS primarily get a diagnosis of depression. And I've talked about why that, you can see that, can understand why that makes sense. But there may be some differences in the characteristics of crying in PBA versus those who cry as a result of depression. So often in PBA, the crying is either way exaggerated, out of line, or is inconsistent with the patient's mood. And again, this can be difficult for an individual that has a brain injury that's crying, and those around them assume that they're crying because they're depressed, and the patient, the survivor, has difficulty communicating that, hey, I'm not really sad. This just crying comes on, and I can't explain it. And so then individuals around them, caregivers, healthcare providers think, oh, well, they're not really being honest about how they feel, and so on. But often inconsistent or disproportionate to the patient's underlying mood, whereas in depression, a patient who is depressed will most of the time readily admit that they're sad and depressed, and that they don't feel well, and they have a sense of malaise, and they don't want to do things, and they have a sense of hopelessness. And so while they may cry, crying is sort of a reflection of that and matches that. In PBA, as I mentioned before, crying is also uncontrollable. So crying will come on suddenly, often without warning, and once the crying starts, cannot stop the crying until it's run its course. So that a lot of times patients will use that expression of, I have to, and I'm using air quotes now, ride it out. Can't do anything to stop it. I just have to ride it out. Whereas crying in depression is mostly controllable. A depressed patient sort of has the ability to suppress their crying or not cry in certain situations, especially embarrassing public situations. Whereas someone with PBA cannot control that. They will cry in very public and potentially embarrassing situations. And with crying in PBA, as I mentioned, it is also relatively frequent, 5 to 7 times a day, if not more. And they also may be very brief. An episode of PBA crying may only last 10 seconds. It may last longer, but it may be relatively brief. Whereas crying in depression, when a person is feeling better, maybe they're not as down one day as they are another day, they're less likely to have an episode of crying on that day. So the crying tends to match their ups and downs of their mood. So what is the significance of all this? What impact does PBA have on a patient who has PBA? So another type of survey was done in which a little over 1,000 individuals who have the different neurological disorders I've mentioned before, brain injury, stroke, dementia, Parkinson's disease, ALS, and MS, were given the CNS-LS again, and divided up into groups of score of 13 or more or less than 13, and they were surveyed on other emotional components. So the individuals, the patients who scored 13 or higher on the CNS-LS are in red, and those that scored less than 13 are in gray. So you can see with these different emotional situations, like do you feel frustration? Do you feel like you're a burden to those around you? Are you irritated? Do you have feelings of isolation and or anger? That the patients who scored 13 or higher on their CNS-LS, which again is suggestive that they have PBA, have significantly greater percentages of feeling these negative emotions than the same type of neurological patients who get a score of less than 13, who probably do not have PBA. So it can really have a significant impact on the way an individual feels, and therefore the way they interact with others and their ability to overcome and accommodate their brain injury. Similarly, looking at some other negative impacts, and again, looking at the CNS-LS scores of 13 or higher, individuals who have symptoms suggestive of PBA have situations where they're less likely to spend time with friends and family, less likely to attend work or professional activities, and are even less likely to go to outpatient rehab therapy. And when I speak to individuals who have been diagnosed with PBA, when they tell me their stories, again, they feel like they're going to embarrass themselves. Through experience, they may have been in a situation where they started crying and laughing, felt very embarrassed in public, felt it was inappropriate, were worried about what others thought of them, and in turn decide, well, I don't want to deal with that again, so I just won't do that anymore. I won't go to church anymore. I won't go to rehab anymore. I won't see my friends anymore. Continuing in this theme, we see more negative impact and the ability to make and keep friends. It's a leading cause of patients becoming further isolated by becoming housebound and just not going out at all. Sadly, it can contribute to ending significant relationships or even divorce, and eventually can lead to individuals needing to live in a long-term care facility or a supervised living facility. So the negative impact of PBA isn't limited to just the patients and survivors. That impact also expands to caregivers and family members. So again, the red bars are caregivers who have someone in their life who has a neurological disorder and a CNS-LS score of 13 or above. And the gray is for those who have someone in their life with a score that's below 13. And so PBA or symptoms suggestive of PBA can have an additional negative impact on caregivers as well. Sharing another anecdotal story where individuals that may have neurodegenerative diseases, for example, and PBA, and where they may have difficulty controlling their bowels or their bladder, and they have an accident and they require their caregiver to help them get cleaned up. And a lot of times that's when they will have, very unfortunately, an uncontrolled episode of laughing. And even though the caregiver knows this is part of the disease state, they're not laughing at me, they don't think this is funny, very often caregivers report to us that it just drives them to the edge of sanity and to the edge of anger and frustration, that while they're dealing with this situation, cleaning up this mess, that the patient that they're trying to help is laughing. And even though they know it intellectually, they feel like they're laughing at them. And this is so inappropriate for you to be laughing that very often they have to step away and not continue to deal with the patient for a short period of time. Okay, so in summary, what I'd like you to walk away with today is that understand that PBA can be part of the symptoms and as a result of brain injury, and that the injury may have disrupted the ability of different parts of your brain to communicate and effectively express emotions. So it's a disorder of emotional expression. And so that if you or if somebody that you know feels that you're having these episodes of sudden, frequent, uncontrollable laughing or crying, it may be PBA, and I want you to feel comfortable in speaking to someone else about it. Don't keep it to yourself. And because the impact of not talking to someone about it can be very long-lasting and significant. And as Deborah said, she has attached a copy of the CNS, or a link to the CNS-LS. It's self-administered. It's 7 questions. If you think that this is something that you might be dealing with, certainly feel free to go ahead and spend a few minutes looking at that and talk to a loved one, a caregiver, or your healthcare provider about it. So happy to turn it back over to Deborah and see if you have any questions.
Great. Yes, we do have a couple questions that came in. The first one was, can smiling inappropriately also be a symptom of PBA?
Well, I think it depends. That's a good question. We've discussed that a little bit. I think if it's a subtle smile, certainly, I think we see it quite often when someone might be nervous. I know when my children might get into trouble, they might start smiling even though they don't know why they're smiling. And that is a little disruption. I think if it becomes an issue in which an individual is embarrassed by it, or they feel it's having a negative impact on their interactions with somebody, that is something that they should consider speaking to a healthcare provider about.
Okay. The second question we had, is there any difference in the statistics for the pediatric population?
So, good question. There have not been any significant studies done in looking at the prevalence of PBA in individuals that are 18 and under in age. So it's a very good question, and I would like to explore that further, but there have been no studies done looking at that younger population, but I certainly think that is a big need now, as not just with accidents with brain injury, but as the community is becoming more aware of the symptoms of concussions related to sports and other activities. That's something that does need to be further examined.
Okay, great. And we had a couple questions about treatment. So are there behavior interventions and or medications for treatment of PBA?
So there certainly can be behavior modifications. I think patients are often recommended to keep a diary. I mentioned that patients can determine that there are some triggers for their episodes. It may be if they didn't get a good night's sleep, for example, they're more likely to have more episodes, or if they're feeling stressed, they're more likely to have some episodes, or even certain environmental situations of it's going to be a really sad event for example, a funeral or something like that. I'm likely to have some episodes. Also, I think what's really important is that it's communicated to family and friends that this isn't a mood disorder or psychological disorder, that the patient's not trying to be disrespectful or difficult. And I think as individuals around them understand, well, this just happens. This is like an individual who has a shoulder injury and they can no longer raise their arm above their head. This is just an objective thing that happens. And I think as more people around become educated about it and are prepared to deal with it when it happens, it then becomes a lot easier to happen. And then again, as far as the treatment goes, since this is a focus on disease state, I'm just going to leave it at is there is one product that has been approved by the FDA for the treatment of pseudobulbar affect, PBA, and so I'll leave that up to the attendees to either Google it on the internet or talk to their healthcare provider about that.
Okay, great. One more question. Does the damage that causes PBA show up in any kind of imaging?
Yes, they can. So a lot of studies have been done over the years, a lot of imaging studies going back to early 20th century, late 19th century, in which anatomical studies were done, and now more with the use of MRIs and CAT scans and functional MRIs. Researchers have been able to narrow down that there are these pathways between the different parts of the brain that are very important, but there are numerous places where injuries can occur, and then PBA can occur as a result of those injuries. So it's not just one specific area where injuries occur. The injury can occur in a variety of different places upon what is believed to be the pathway.
Okay, thank you. We don't have any other questions. We got a couple more minutes if somebody has an additional question. We have time to answer that. If not, you can always contact me and we can get your answer to you later if you have a question later. Dr. Winterling, thank you so much for this presentation. Great information. Thank you everyone for attending and joining us today. So, I got one more quick question.
Okay.
So there's no definitive diagnostic test for PBA?
No. So the CNS-LS is often used, but it is up to an individual physician to diagnose. So they may use the CNS-LS or another screening tool as a guideline. But the important things are that they are episodes of laughing and crying that are sudden, frequent, and uncontrollable. Also, it needs to be established that these episodes of laughing and crying did not occur prior to the injury, so it's different now that the brain injury has occurred. And they sort of remove other possibilities, like, as I mentioned, it's not due to a result of medication or drug abuse or alcohol abuse. It's not a result of a mood disorder such as schizophrenia or bipolar. And so a physician has to incorporate all those different aspects. So unfortunately, there's not just a black and white test that says yes, an individual has PBA or does not have PBA.
Okay, great. Thank you so much for that additional information. I appreciate it. Thank you for joining us, everyone. And I think we're just about out of time. So everyone have a good afternoon. Thank you.
Yes, sir. Have a good day. Thank you.
Thank you.